Dimitrios Gavras, pediatric cardiologist from Athens, who will speak about role of preoperative echocardiography in congenital mitral valve anomalies.
Good morning. First of all, I would like to thank the organizing committee and Professor Kalagos in person for inviting me here today. I feel very, very honored to be in front of some very distinguished pediatric cardiologists from all over the world. It has already been 12 years that I left UK, so my ability in English is quite rusty, but I will try to get you some information about the role of preoperative echocardiography in congenital mitral valve anomalies. So the mitral valve is a very complex 3D mechanism, and each smooth function is the result of a perfectly coordinated interaction between the annulus, the leaflets, and the subvalvular apparatus, consistent of chordae tendineae and papillary muscles. The annulus is saddle-shaped, as you can see. We have two distinct leaflets, the anterior and the posterior. The posterior one is attached to the 2/3 of the annulus, whereas the anterior leaflet is attached only to 1/3 of the annulus of the mitral valve. In the posterior leaflet, we have three distinct scallops named P1, P2, P3, and the opposite area in the anterior leaflet are correspondingly named A1, A2, and A3. We also have two papillary muscles, the anterolateral and the posterior medial. However, Professor Anderson, just 5 minutes ago, changed the nomenclature. This is what the mitral valve looks like from the surgeon's eyes. So, as he sees the mitral valve from the atrial side, and on the right, we have what we see as echocardiographers from the apical view. Congenital mitral valve disease. It's a very complex and wide group of heterogeneous entities which account for 0.4% of all the congenital heart disease. As we said, they are very heterogeneous, so they have variable anatomic characteristics and prognosis. They may affect multiple segments, from the supravalvular region to the annulus, to the leaflets, to the commissures, and the subvalvular region. Overall, mitral valve repair is generally preferred over the replacement. And the reasons for this tactic is the preservation of the subvalvular apparatus and its function, the conservation of overall ventricular geometry, the tissue and patient growth, and the avoidance of anticoagulation therapy. However, it is challenging due to the diverse and complex morphology, which affects both the valve itself and the subvalvular apparatus. The surgical results have been burdened by a non-negligible proportion of reoperation for either reconstruction or replacement. When we talk about congenital mitral valve disease, we mainly refer to the mitral ring, to the double orifice mitral valve, to the parachute valve, to the hammock valve, to mitral valve prolapse, and to the isolated cleft. This is the mitral ring. We have two different categories. The supramitral ring, when we have Is there a pointer here? Okay, okay. So on the left, we can see the supramitral ring, which is a fibrous membrane originating just above the annulus, and usually it is not adherent. But it doesn't appear there. Okay, thank you. The membrane is not adherent to the leaflet, and it is usually associated with normal subvalvular apparatus. On the right, we see the second type, where the membrane is located within the valve. It is adherent to the leaflets and usually presents in association with abnormal subvalvular apparatus. The ring may be complete or partial, and usually create a stenosis to the flow at various degrees that tend to be progressive. Θα μπορούσατε παρακαλώ να ενεργοποιήσουμε. So this is a video from a ring, supramitral ring. We can see the flow acceleration just there. It's very evident. Here, on the next one, please, we can see from the apical view the same flow acceleration across the valve. On the next one, this is the transesophageal echocardiogram. We can still appreciate the flow acceleration. And in the last two videos, at the end of the videos, we can see the membrane just here and here. Next entity is the double orifice mitral valve. So we have an accessory bridge or limbs of tissue, partially or completely dividing the mitral valve orifice into two orifices. We have three types: the incomplete bridge, the complete bridge, and the whole type. We have two specific echo signs: the presence of two circles opening in the diastole, and we can see that in a short axis view, two circles, and on the δεν φαίνεται καλά. There are two distinct inflow jets, but it is upside down. Sorry for that. For some reason, it reversed. No worries. Let's move to the next one, parachute mitral valve. The mainstay of the diagnosis is a single papillary muscle. We have insertion of usually shortened, thickened, and often fused chordae into a single papillary muscle. The intracaudal spaces are partially or completely obliterated, commissures are often underdeveloped, and the leaflets may be dysplastic or deficient. On the echo, we see a single papillary muscle, and this echo is very nice. We can see the shortened chordae and how they are attached into a single papillary muscle. A very nice presentation of a parachute mitral valve. Next one is the mitral arcade or hammock valve. Here we have a normal connection of the papillary muscles to the leaflet, either directly or through the interposition of unusually short cords. The papillary muscle resembles two pillars with a bridging fiber of tissue in between the papillary muscle. We have thickening of the leaflets and shortening and thickening of the tendinous chordae. If we can play the videos, please. We see how restricted is the opening of the mitral valve. We see that the papillary muscles are almost directly attached to the tips of the leaflets. And we have the mitral valve prolapse, either the anterior leaflet only or bileaflet mitral valve prolapse. And we see the significant mitral valve regurgitation and the dilation of the left-sided structures. And finally, we have the isolated cleft. In the transesophageal echo, it might go undetected. We have some billowing on the posterior leaflet, but when we put the color flow Doppler, we can see two different jets, one eccentric, and the 3D reconstruction give us the diagnosis. We have an isolated cleft between the P2 and the P3 scallop. However, we have disease changes in the mitral valve associated with other congenital heart disease, like stenosis in the hypoplastic left heart syndrome, severe or critical AS, cleft in partial AVSD, complete AVSD, the Sones complex, or the Al-Kappa. So the first video is a complete AVSD. The second one, here it's a baby, a small infant with Williams syndrome, critical AS, very underdeveloped aortic root, and also mitral prolapse. The third one is another case of severe AS. And the fourth one is Al-Kappa. We can assess the mitral regurgitation and the brightening of the papillary muscles due to the ischemia. So in the daily practice, we use the classical transthoracic echocardiography with these four views. However, they are views from a single plane, so we cannot assess the whole mitral valve, but just parts of it. In the parasternal long axis view, we can assess just the P2 and A2 scallop, parts of out of the 6. In the parasternal short axis, we can assess all 6 parts of the leaflet. And on the apical views, we can get assessment of just 3 out of the 6 parts of the leaflet. However, a comprehensive and accurate echocardiographic assessment is critical preoperatively to gauge the surgical result. 2D transthoracic, epicardial, and transesophageal are the most frequently used imaging methods worldwide. However, 3D provides the simultaneous assessment of the spatial relationship of the leaflets, the chordae, and the papillary muscles, and thus more accurate and reliable measurements which have the potential to aid surgical planning. So what is the ideal echocardiographic study that will give information to the surgeon? It's the one that will depict the valvular anatomy in with many details. The ideal echocardiographic study will give us some quantitative parameters, semi-quantitative assessment of the left and right structures, and any possible associated congenital heart disease. The diagnosis of the defect is generally made by 2D transthoracic. However, the transesophageal and the 3D provide additional information to guide the management. When we are talking about the valvular anatomy, we have to scrutiny to get a very segmental approach from the supravalvular region to the papillary muscles. So we start from the supravalvular region looking for mitral rings. Then we go to the annulus size to assess if it is normal, hypoplastic, or dilated. Then we go to the leaflets, and we are looking about thickness, dysplasia, deficiency, underdevelopment, cleft, motion abnormalities, and the presence of accessory tissue. Then we go to the tendinous chordae, looking and assessing the attachments and the anatomical details, if there is thickening, shortening versus elongation, if the intracoldal spaces are obliterated or fused. And finally, we assess the papillary muscles about their number, their size and location, if they are hypertrophied, fused, elongated, and their position and symmetry. Quantitative parameters in mitral valve stenosis in children who have no parameters to rely on. There are various parameters for the adults, like mean transvalvular gradient, pulmonary arterial systolic pressure, and valve area. However, the consensus statement from August 2024 of the APC says that we have lack of validated quantitative or semi-quantitative parameters to classify AV valve disease severity in pediatric patients. So, if we would like to get information and assess quantitative parameters in mitral valve stenosis in children, we should assess the transvalvular gradient, the orifice area, and the annular diameter. We need to take into great consideration that all of them are affected by significant physiologic variations with growth. The cutoff values to estimate disease severity, if applicable, should be modulated according to age and body size. High heart rates to be considered, and the impact of coexistent shunts to be considered as well. The Doppler VTI of the inflow tracing from mitral valve inflow give us information about the mean gradient. However, studies comparing the accuracy of this gradient estimated at echo with those derived from invasive assessment are limited, so pediatric normograms for mitral valve velocity time integral are absent. The mitral valve area can be assessed by 2D echocardiography. However, normograms are limited. The annulus measurements are reproducible by 2D echocardiography, and luckily, robust normograms are available. What about the semi-quantitative assessment? For the evaluation of left atrium dimension, in cases of moderate to severe stenosis, we know that the LA wall bulges to the right, the left atrium is dilated, and for the LA dilation, Z-scores are available. For evaluation of the LV dimension and function, in case of LV dilation, we can have LV dilation wherein there is both stenosis and regards, and we can have hypoplasia, example given in Sohn's complex. We need to indirect estimate the systolic pressure of the right side from TR. And also, we need to take into consideration the characteristics of the PFO shunt. What is a 3D role in mitral valve stenosis in children? It helps to better appreciate the anatomy of complex mitral stenosis, including double orifice, ring, arcade, and parachute. It is helpful preoperatively in planning the surgical strategy by unfast view of the valve anatomy and the identification of the principal site of stenosis. The anatomy of chordal support apparatus can be defined in a manner that is not possible by the 2D. More precise measurement, and it gives more precise measurements of the annulus and the mitral valve area. Regarding the quantitative and semi-quantitative parameters in mitral valve regurgitation, there are no clear criteria to grade disease severity in the pediatric age group at present. Still, we have to, the indirect assessment of AV regurgitation severity be made by evaluation of the chamber size and the RV pressure. What is the 3D role in the regurgitation in children? It allows for more precise measurements of the annulus, of the mitral valve area, the effective regurgitant area, the PISA, and we can make the planimetry of vena contracta area, which is considered a very precise quantitative method due to the unfast visualization of the real shape of the vena contracta in a short axis view. So there are strong reasons for favoring 3D echo techniques to assess, monitor, and assist in the decision-making in children with mitral valve disease, because the range of morphology is well visualized and the effective orifice area and the regurgitant area can be measured without assumptions about the shape of the orifice and the regurgitant region. The era of technological innovation will bring 3D approaches to younger and smaller patients. The introduction of pediatric 3D transesophageal probes facilitates adoption of 3D intraoperative approach to new cohort of patients, particularly infants with mitral valve disease. AI might also assist with automation of measurements to produce rapid, accurate, and repeatable measurements such as effective orifice area and vena contracta regurgitant area, which are relevant to mitral valve repair. This is a paper from October 2025. It refers to the adults, but the mainstay of the information is the same. In cases of MR, the 3D gives pivotal information for leaflet morphology, annular geometry, and subvalvular structure across all carpe diem subtypes. The 3D color mode improves spatial localization of regurgitant jets and enables advanced MR quantification techniques. In MS, the 3D planimetry via transthoracic or transesophageal echocardiography provides more accurate and reproducible measurements of the mitral valve area compared to 2D. And the final conclusion is that the 3D echocardiography has redefined mitral valve imaging by offering unparalleled anatomical and quantitative assessment. My last slide is a paper from Boston. It is not that relevant to my topic about preoperative role of echocardiography. It is post-surgical. It refers to the post-surgical patients. It is a comparison of 2D and 3D echocardiography accuracy in discriminating mitral valve reoperation by area under the curve analysis. It refers to 200 patients from Boston Children's, a very recent paper, and the changes of the 3D effective orifice area and the 3D vena contracta regurgitation area predicts more accurately the need of reoperation in these patients if compared with 2D mean gradient and 2D vena contracta area. So, the take-home messages are that the mitral valve is a complex 3D mechanism. It's the congenital disease, as we said, is a group of entities with variable anatomic characteristics and prognosis. The repair is generally preferred over replacement. A comprehensive and accurate study is critical preoperatively to gauge the surgical results. There is lack of validated quantitative and semi-quantitative parameters to classify valve disease severity in children. The 2D transthoracic, epicardial, and transesophageal are the most used imaging methods worldwide. However, the 3D gives simultaneous assessment of the spatial relationship of the leaflets, chordae, and papillary muscles, gives more accurate and reliable measurements, and there are strong reasons favoring the use of 3D techniques now and in the future. Evolution will bring 3D approaches to younger and smaller patients, and AI might assist with automation of measurements such as effective orifice area and vena contracta area. Thank you.
Thank you very much, Dr. Gavras. Really an impressive presentation.